Hello, it's Melissa Sweet here from Croakey. We're at the beginning of the Navigating Health for Croakey Go, coming to you live from Melbourne. We'd like to acknowledge the Victorian Aboriginal Health Service, which is hosting the launch of our Croakey Go today, and would like to pay our respects to the traditional custodians of this country, the Wurundjeri people of the Kulin Nation. We're about to talk about social prescribing. Sarah, could you please introduce yourself? Tell us a bit about who you are and what you do and what your connection is to social prescribing.
Sure, Melissa. My name is Sarah O'Leary and I'm the Director of Integrated Care at Northwestern Melbourne Primary Health Network. Northwest Melbourne Primary Health Network are currently supporting a pilot in social prescribing with partners from IPC Health, Bringbank Council and Victorian University. That pilot is really about looking at how we can explore introducing a social prescribing model into the Victorian primary care sector. And social prescribing in essence is about connecting people with social organisations in their community to help them support them with connecting with people or
so it's an alternative to pulling out a prescription pad for a medicine.
Absolutely,
in some ways,
yes.
or complementary, not necessarily alternative.
So the traditional model is obviously to support people with medication or therapies, and what social prescribing does is it acknowledges that people have other issues or concerns in their lives that can't be treated with medication, and it's about helping them to find what those to understand what those concerns are and connecting them with organisations in the community that can support them to.
Now, I'm just thinking of GPs or other health professionals who might be watching this. Wouldn't some of them say this is what I'm doing already?
Potentially, yes. I think it's about giving them another alternative or an extra therapeutic chink in their armoury, so to speak, to support them to kind of help their patients. So it's not to overtake what they're currently doing, but actually just to add another approach or alternative that they can support their patients with.
So what are some of the things that they might, the types of organisations they might recommend contact with?
So if you think about social prescribing and the types of issues that people have, it's quite often, jobs, education, social connectedness. So it's about finding those organisations in the community that can help them with that. So some of the things that people might be linked in with are, for example, gardening clubs, job support, financial and legal aid. So it's about giving GPs, I guess, extra connections to organisations in the community that can help people and are potentially better placed to help people with these types of concerns.
Right. So am I right in thinking that social prescribing may have arisen in the UK?
Yes, that's right. Yeah, so there's quite a large social movement in the UK at the moment around social prescribing, and the NHS have invested heavily through their Vanguard sites and their primary care trusts and networks. And the evidence so far is, while probably not at a large scale, there is kind of pockets of really good evidence to suggest that social prescribing can result in reduced admissions to hospital, and in one case, reduced mental health admissions at one site by a third. As far as I'm aware, yes.
Wow, that's quite significant. So what's the state of play in Australia? You've mentioned the work that the Northwestern Melbourne PHN is doing. Are there other PHNs doing work in this area or other organisations that you're aware of?
We have certainly had interest from other organisations hearing about the social prescribing model that we're undertaking. I'm not aware of any other that are actually currently implementing. Certainly in New Zealand, there has been trials of kind of social prescribing models in the past that have looked at park and green scripts. So, and that's about kind of ensuring or trying to motivate people to, use their parks and leisure centres more frequently. But not that this is the first kind of model of its kind in Victoria, as far as we're aware.
So can you give us an idea of the timeline? When did the pilot start? What's it actually going to entail? And going forward, what are the key points?
So we started probably about 18 months ago, and with all of these things, it's about building relationships. So it was important for us to establish a relationship with the organisation implementing the model. So that's IPC Health. Also with Greenbank Council. So also councils play an important role in terms of connecting the organisations in their communities with primary care. And also with Victorian University, who are interested in I guess the evidence and effectiveness of it. And the model itself started, I guess, was being rolled out earlier this year. So far, we've been able to map the assets, or I guess map the organisations in the community that people can be referred to. And we're just starting to see, we also have recruited the community link workers, and the community link workers play a very important role, if not the most important role in the model, in that they're the person that has the connection with the patient to understand what those issues are. And they also understand and have a very good knowledge of the service or organisation directory in the community, and they're the person who finds out where that patient or client can be referred to. So they've been recruited, and we're just starting to see the first few patients through the trial, which is really, really exciting.
Fantastic. So that's literally in the last few weeks that
yes. So June, yes, June of this year.
And so when will you have a sense of what difference this has made in a rigorous sense?
That's a really good question. I think it will, like all pilots, it will take time. To get that kind of outcome level data. I think we've kind of put some evaluation measures in place that will give us early indication around how it's progressing and how it's tracking. How many people are kind of staying in the programs that they're referred to, and what are some of the clinical outcomes that a GP might expect to see change if someone was to be referred to social prescribing.
So have you thought about what are some of the likely barriers to its uptake, and also facilitators, what will help and what may not?
Really great questions. I think barriers, similar to all quality improvement programs in general practice. I think it's around general practice, time, and ability to kind of embed this in an ongoing way in general practice, and that takes a lot of time and a lot of change. So I think having simple processes and systems that GPs and their practice nurses and the whole practice can take up would be a really important facilitator of social prescribing. So making it really easy for people to do this. And I think other barriers also include, or maybe not barriers, but facilitators, actually, if you look at the positive, is finding the right type of people for that community link worker role. So essentially these people are motivators and are responsible for kind of meeting with people, understanding what matters to them, engaging with them, and ensuring that their patient journey is improved. So it's really important that we find the right kind of role and function for that community link worker.
Presumably local people, that
yes.
know the local networks.
Yes, know the local networks. Not necessarily clinicians, so could be peer workers. So it's about finding that balance, and I think we have some good models from the UK that we can draw on for that, but yes, it's
Now, just to ask a cynical question, which is, we have problems in health with so many disciplines not working together. Are we just creating another category of health worker? Is it just creating another layer, I guess, is what I'm asking.
That's another really good question. I think the evidence from what's coming out of the UK is that the multidisciplinary teams that are being established through these models are actually quite effective, and it's another, as I mentioned earlier, it's another place for a GP to go to look for help to support these clients. So it is important that they're embedded and not just an add-on to the system.
Now, Sarah, I'm just going to turn around so that people can see where we're actually standing, which is in the courtyard of the Victorian Aboriginal Health Service ahead of our Croakey Go. And the reason for pointing this out is that, you could think that Aboriginal community-controlled health services have been doing this sort of work for a long time already. They're just doing it. We have a model.
Yes. Yeah. I believe we can learn a lot and draw a lot from the well-being model that Aboriginal community-controlled services have, well established in Australia. I think the focus beyond the physical and the biomedical model is really important, and I think there's a lot that we can draw on from these organisations, and the sense of community and connectedness that they have that essentially social prescribing is trying to create as well.
Fantastic. And for people we're just about to wrap up, people who've joined us along the interview, can we just end with you reminding people watching who you are and what your role is?
Sure, Melissa. My name is Sarah O'Leary, and I'm the Director for Integrated Care at Northwest Melbourne Primary Health Network.
Brilliant. Thank you so much.